student, we're going to start with our lecture, Management of the Client with Digestive Disorders. And specifically, this PowerPoint will address the upper and lower gastrointestinal problems. Next slide. So these are some of the conditions we're going to talk about for the upper GI. Gastroesophageal reflux disease, very common. Gastritis, peptic ulcer diseases, and gastric cancer. Next slide. All right, so let's talk about the manifestation, the common manifestation and cause for some of these diseases that we just referenced. So pain or tenderness. You know, the patient may also complain of nausea or fullness in their belly, anorexia, or vomiting. So the pain that they receive or they experience is usually due to some type of chemical irritation of the nerve endings, right? So that's what pain is. Those individuals that have diabetes, those nerve pain, those pain are worn out. So their symptoms may be a little different. Anorexia or fullness, and this is because of the slow emptying of the gastric system. Or nauseous because of the tension on the walls, and they vomit because of the increased pressure in the medulla, which is stimulated. There's, increase in the nerve impulses, causing the vomiting. Okay, next slide. Also, they may bleed, and this bleeding is usually due to the local trauma or the irritation to the mucosa, diarrhea due to the increased peristalsis, right? Or they belch or flatulence because of the air that they swallow, right? Or incomplete digestion, or they experience indigestion because of the GI disease, the gas-forming foods, the poor manner or allergens to food. Next slide. So we are going to start with our first disease, which is gastroesophageal reflux. So pretty much the length and frequency of the acid that is exposed to the stomach, to the esophagus, creates a problem. Hydrochloric acid, pepsin, bile acids, and the pancreatic enzyme. And so we know that the stomach is really acidic, right? However, the esophagus is not as acidic. And so when you have acid entering that area, it's definitely going to alter the normal surface. So the pH is usually less than 2.0, right? And if that happens, then of course there's increased diffusion potential and at the surface epithelial cells, leading to cellular permeability, which cause the hydrogen ions to penetrate through intracellular space. All right, and of course that ion reach deeper into the sensory nerve ending, and voila, patient complain of heartburn. All right, next slide. So this slide is showing you the sites of some GI pathology. So if someone is diagnosed with esophageal cancer, it's above, it's not in the stomach because it is an esophageal, so it's the upper part of the esophagus, and that's the same area where esophageal varices may form, and we'll talk about that a little later as well. Gastritis, and then gastric ulcer and the gastric cancer, it's in the stomach, versus the duodenum ulcer, which is at the duodenum area. All right, next slide. So, acute gastritis. So what is it? Right? What is it? It's a transient inflammation of the gastric mucosa, right? Many things cause it. Some of the things that are causing these problems are bacteria. H. pylori is a big one there. Some of our lifestyles, such as caffeine, alcohol, smoking. Sometimes things we cannot avoid, which are drugs, steroids, aspirin, and NSAID. And, aspirin and NSAIDs are very commonly used drugs over the counter. Bile reflux, or client that have that are burned, in shock, or sepsis. All right, and it can be based on severity, so moderate, edema to the point where someone really have some hemorrhaging and erosion. Next slide. So what happens with acute gastritis? Well, we know there's a break in the mucosa, right? Break in the mucosa barrier. And when that happens, there's going to be diffusion that takes place, which is hydrochloric acid, pepsin, all that goes into the mucosa, leading to a disruption of it, right? A disruption of it. Disruption of the mucosal capillary membrane, which will in turn release histamine. Histamine is released in response to that injury, right? Which causes the vasoconstriction, leading to the release of prostaglandins. And prostaglandins, fatty acid component, it has like hormone effect. And this causes, the cells, the increase in permeability, therefore leading to vasodilation. And that dilation would lead to the protein leaking out into the lumen, causing vessel to erode. And when the vessels are eroding, it will lead to a big issue, which is hemorrhaging, right? Which is hemorrhaging. So this is what happens, and we want to prevent this from happening. So you have that break in the mucosa, which, because there's a break, now you have an entry point, right? So the fusion takes place where you have acid entering into the area where it shouldn't be, all right? And that disruption of the mucosa and the capillary membrane causes the release of histamine, right? Because now there's an injury, so histamine is going to be released, leading to prostaglandin being released. That causes the vasodilation, and then that causes, the protein to get into the gastric lumen, leading to the vessels eroding, therefore causing hemorrhage. All right? Next slide. So what are some of the common manifestations? Well, it depends on what is the cause, the common manifestation related to the cause, right? It depends on what are that. So aspirin, usually they may be unaware, they may have heartburn or sour stomach, all right? And that leads to, generally when you have an aspirin, it can lead to complete regeneration of the mucosa within several days, right? Or staph, an abrupt or violent onset, usually 5 hours after ingestion of some type of contaminated food, Staphylococcus aureus. That too can usually regenerate. All right, alcohol, transient vomiting, and GI bleed. So the body has the ability to regenerate, right? Caffeine, tea, pepper, radiation, and chemotherapy. All this can cause acute gastritis. All right, next slide. All right, so let's talk about some nursing diagnosis as it pertains to gastritis. So 1, gastric tissue perfusion. That makes sense, right? Related to blood loss or nutritional secondary to loss of acid secreting cells, right? Another one is ineffective breathing pattern related to increased pressure against the diaphragm, secondary to GERD, secondary to abdominal distension and pain. Next slide. Now we're going to talk about chronic gastritis. So chronic gastritis has many causes and depending on the location as well. One location is the fundal, like the top of the stomach versus the ant rheal, and that is, like closer, to the esophagus area near to the stomach, right? So it occurs in the esophagus, near the stomach, right? That area. So the fungal type of chronic gastritis is usually caused by, autoimmune, factors. Autoimmune means that the body decides to kind of take over or destroy its own self and not recognizing the normal cells. And so there are circulating antibodies, parietal cells, or intrinsic factor, right? We're going to talk about intrinsic factor. They are associated with pernicious anemia, Addison's disease, Hashimoto's thyroiditis, right? And what usually happens is they have like a multiple burst of intense period of gastritis. Type B, the antral, usually related to H. pylori or some atrophy of the gastric mucosa. Next slide. So the pathophysiology, it's pretty a significant problem because half of the world population is colonized with these H. pylori, but many of the individuals do not develop the disease. So H. pylori, it is bad, it's a bacteria, very hard to kill. So part of the treatment is multiple drugs. What happens is, that the acid, the stomach has a lot of acid, right? There is bicarb that helps neutralize things. So H. pylori decreases the bicarbonate secretion, right? And what it happens is it degrades, because of that, it degrades the mucosa, and then the patient develops, peptic ulcer disease, or even worse, metastatic disease, right? So going to chronic gastritis and the worst case scenario, gastric cancer. So H. pylori is really significant when it comes to gastritis, and to ensure that we treat it to eradicate this disease because of the issues that it can cause, and the most alarming of it being gastric cancer. Next slide. So the way H. pylori infiltrate the cells is really an interesting process. So it penetrates the mucosal layer as seen in the item there, or the picture there, and it forms cluster near the membranes of the surface epithelial cells. Next slide. All right, so the second stage is that some H. pylori, like you see, they would attach to the cell membrane, and some of them will lodge between the epithelial cells. So they get in there pretty aggressively. Next slide. So diagnostic test for H. pylori, it's usually we can do non-invasive test, the stool or the breath test, right? Or biopsy. The biopsy of the antral mucosa with rapid urase testing. Right? Biopsy will be the most definitive to confirm the diagnosis. Next slide. All right, so how do we manage this condition, this H. pylori, this bacteria that invades the cells so much? Well, I told you that we need to eradicate it. So there's usually combination therapy in up to 85% of the cases. So they take antibiotic, anti-circulatory drugs, or cytoprotective drugs. So that means antibiotic, and usually, flagyl, amoxicillin, Claritin, clindamycin, and the anti-circulatory are the ones that secrete the most acids are the proton pumps. So we want to use the proton pump inhibitors. And then to protect the layer, Cytotec, Carafate, Pepto-Bismol. All right, so it's a throughput therapy, and usually for about 7 to 14 days, right? 7 to 14 days. Next slide. All right, stress, drug-related mucosal diseases. And so now we're talking about peptic ulcer disease, right? And there's different types. There's duodenum, and then there's gastric. All right, duodenum and gastric. Duodenum ulcers, usually gets better with food. And so what happened here, the secretion um, of acid is usually, due to, the rapid entering, there's decreased buffering effect, there's increased acid in the duodenum, and there's penetration of the lesions, usually up to 1 to 2 centimeters. And so the neutralization with food actually helps relieve the symptoms, and that's why duodenum also gets better with food. Whereas with gastric, the food actually increases the gastric production, causing more pain. So it doesn't get better with food. It gets better with empty stomach, right? So with gastric, there's gastric erosion, and then there's breaking in the mucosal. The incompetent pylorus helped in that, and then of course the superficial lesions are present. Next slide. So what you see here are, the different issues with it that Bepler's ulcer disease will cause. There could be trauma. Sometimes it could be caused because of a patient that is, burned, head injury, NSAIDs, aspirin, steroid, alcohol, or shock can cause that. All right, and we'll get to talk a little bit more about the differences in these ulcers, and compare it a little better. Next slide. So some of the complications of gastritis include upper GI bleed. So it's hemorrhage, which is in 25% of the patients have, massive bleed, 2,500 ml. That's a lot, and it's usually, sudden, or it can be insidious. The severity varies. Artery bleeds. It could be artery, venous, or capillary. Next slide. So there's a significance of the vital signs, and this is why we as nurses, we got to monitor it, because when someone is bleeding, there's a change, and usually the blood pressure will change by 10 millimeters per, or the heart rate goes up. So you know how when someone is hypertensive, the blood pressure is dropping, right? That's what hypertension is, and the heart rate goes up to try to compensate. And when this happened by 10, BP drops by 10, heart rate goes up by 20, it means that there's at least 1,000 cc's of blood that is being lost, and which is equivalent to 20% of the total blood volume. That's a lot of volume that is lost, and so you see the difference. So if someone is losing 2,000 cc's, that's 40%. So it's important for us to address that. There are also other adaptation or ways for the body to adjust or try to stabilize itself, right? So the heart rate goes up to try to accommodate for the low blood pressure. It's one way. So let's look at the other two. And now we're going to talk about, the nervous system and the endocrine system trying to also compensate for the loss. Okay, next slide. So the nervous system, pretty much, if there's a stress, in this case the bleeding, right? So the vasomedullary center, which is a portion of the medulla oblongata, will try to regulate the BP, and other homeostasis processes, right? So it's activated, and when that happens, it activates the sympathetic nervous system, right? And that is the fight or flight response, right? And so with that, the release of epinephrine, norepinephrine in the bloodstream is effective, and therefore triggering the alpha adrenergic receptor stimulation and the beta receptor stimulation. When the beta adrenergic receptor is stimulated, what happens is that there's increased cardiac output, right? So remember, the patient is, their cardiac output is low by 20%, in this case, 1,000 cc's of blood loss, right? So the increased cardiac output, increasing the myocardial perfusion, because we need to have adequate perfusion. Whereas the alpha adrenergic receptor stimulation, that, stimulate the peripheral to cause vasoconstriction. Vasoconstriction increases the blood pressure. All right? Next slide. Okay. Um, so now we are looking at the endocrine review of how it tries to address the decreased cardiac output and hypotension. And so when that happens, when the cardiac output is low and there's hypotension, there's a stimulation of the release of renin and aldosterone from the adrenal cortex, right? So renin is released from the kidney, and so it's good for the kidney to work, right? Which triggers for the liver to create and release angiotensin, right? Angiotensin 1 has to be converted into angiotensin 2, okay? So that is required. That happens in the kidney, in the lungs. So nonetheless, you have the angiotensin, which is a vasoconstrictor, right? Very potent vasoconstrictor. So you can see when that constrict, you see how the blood pressure will go up. With the aldosterone, it's increasing the sodium absorption, therefore holding on into the fluid, right? So antidiuretic hormone, against diuresis. So because my cardiac output is low, I'm hypotensive, I don't want to diurese. I want to hold on to it because I have less of my cardiac output. I've just lost, in this example that we use, 1,000 cc. All right, next slide. All right, so in this slide, we are looking at the first level assessment, usually when the person is trying to compensate. So there's oxygen and there's tilt test. The tilt test is a test that is used to measure how the blood pressure and heart rate respond, to the force of gravity, right? To the force of gravity. And what that means is that the patient's usually in lying position, and then they change the position into standing, and what happens is there's a drop in the blood pressure and tachycardia. So that's the tilt test. It's positive, it's positive because there's a drop when position is changed. Of course, we have to monitor the pulse and EKG when this test is done, because it's usually we have already assessed that the patient may have a positive tilt test when this test is done. So you see the pulse is increased, baseline, blood pressure is normal, and then systolic drop, diastolic drop, respiratory rate goes up, which will lead to respiratory alkalosis with the tilt test, and the skin that will repair, cool, and delay capillary refill. So it's positive tilt test, and it's positive because of those changes. All right. Neurologically, you'll see some assessment finding as well. So they're restless, irritable, apprehensive, alert and oriented, pupils are dilated and reactive. All right. All right, with fluid and electrolyte, slightly decrease in urine output, and there is also a decrease in thirst. All right. Next slide. All right, sites of upper GI bleed. Here's the different sites of upper GI bleed. So I believe we've already talked about this, but esophageal varices on the top is in the esophagus. There's Mallory-Weiss tear, a tear or syndrome, gastritis, gastric ulcer, and gastric cancer. Esophageal cancer, it's also up there, and duodenal ulcer. Next slide. All right, so this is the etiology of upper GI bleed. We want to pay attention to the GI bleed can happen in the esophagus, upper GI, or the stomach, or the duodenum. The bleeds that are stomach or duodenum, you are due to these are the different causes. peptic ulcer, the medication that the patient is taking. You've heard of aspirin and NSAIDs. It could be caused based on gastric cancer or stress ulcer, right? Stress ulcers can be from either a client who has burn or a client that have head injury, right? So what happens with the burn injury is that the acute gastric erosion, right, reduces the plasma volume, right? And it happens in both the brain injuries as well. So if it's burn, we call it Curlin ulcer. If it's the brain injuries, we call it Cushing ulcers. And so this lower volume leads to ischemia, right? And so usually for the Cushing's ulcer, again, what's happening is this usually because of the increased intracranial pressure. But the physiology is the same, but the names of it is different. Burn, you see ulcers that we call Curlin. Brain injury, because of increasing intracranial pressure, we call it Cushing's. All right. Mallory-Weiss, for the esophagus, the type of bleeding usually occurs because of chronic esophagitis, or someone that has Mallory-Weiss tear or esophageal varices. Well, chronic gastritis is a chronic over time exposure to acid in the esophagus, right? So over time, it's going to bleed. Mallory-Weiss is usually due to, someone who's vomiting, like severe prolonged vomiting, right? That causes a tear in the esophagus, right? And so that would be a question you want to ask, is the patient, what is happening? Were you vomiting previously to collect data? Or esophageal varices, this is complications from hepatitis, and the veins in the esophagus, they bulge. And when they bulge, they can bleed, right? Causing, esophageal varices. And we're going to talk about those complications later as well. Next slide. So we are going to be talking about each one of these conditions closely. All right. So like I said, Mallory-Weiss, I told you that it's a non-perforating tear of the gastric mucosa. Vomiting is usually when that happens and is associated with alcohol use, hiatal hernia, gastritis, and esophagitis, right? Versus esophageal and gastric varices, usually due to chronic liver diseases. There's increase in portal hypertension causing the pressure and dilation of the esophageal vein, like stated earlier. Next slide. So we need to ask about their history, right? The history. So pretty much you want to find out any precipitating or alleviating factors, any use of substances and abuse, vomiting, stool, upper GI bleed. Usually the stool will be tarry, not bright blood, because it's gone through the digestive system and therefore it's darker. The diet history and stress in their life. Next slide. All right, so clinical manifestation of upper GI bleed. Usually there's burning or cramping in the mid-epigastric area, there's nausea, and there's possibly vomiting. Normal or increase in bowel sounds, and hemorrhage or perforation may be the first symptom. Next slide. Hemorrhage. Common in duodenum versus the gastric ulcer, right? And it's also common with varices. Clinical manifestation that someone is hemorrhaging is, vomiting blood. So bright red or coffee grind type of look blood. The stool, you see melena, maroon, or burgundy. Fluid volume deficit would definitely be a nursing diagnosis here. All right, because there's deficit in fluid volume, you will see H&H looks like it's hemoconcentrated, so increase H&H. Okay, increase BUN initially because the fluid volume is down, right? Because BUN by itself can tell you dehydration, right? But once the volume status is corrected, both of them will go down. It makes sense, right? Because now it's not as concentrated. So position and safety is really important for these guys. Next slide. So, nursing diagnosis. Just finished talking about this slide. But next slide. So, nursing diagnosis: fluid volume deficit, altered tissue perfusion, right? So, fluid volume deficit, the presence of loss, correlates with the manifestation that they have, level of consciousness change, skin signs, poor capillary refill, the blood pressure will go down, heart rate will go up, urine output, if it's not corrected, of course, will be less, right? Next slide. All right, so what are some of the collaborative management? Well, to establish an IV access and try to replace the fluid. If it's clotting factor is an issue, crystalloid, replace them. Monitor the vital signs frequently. Gastric lavage, so put a large bore NG tube, and so you know how to measure it, the NG tube from the nose to the ear to the xiphoid process. On room temperature saline, we may want to anticipate that the patient will be transferred to a critical care if they're not hemodynamically stable, because if they're not, we want to be able to monitor them a lot more invasively than just taking manual blood pressure. There's diagnostic endoscopy, definitely, because you want to find out exactly what is going on and what part of the stomach is involved. Next slide. All right, so for ulcers, your collaborative management, we do like endoscopy, right? Because we want to go in and look and see what's going on, because we may want to stop the bleed, depending on what's happening. For varices, we know that the vessels are bleeding, so we can put agents on them to try to stop the vessel from bleeding. We can put a band to try to form thrombosis and fibrosis of the bleeder, or vasopressin and IV nitroglycerin, or balloon pump. It's inserted to try to inflate the pump, the balloon, so that it could put pressure on the site that is bleeding. Next slide. All right, so the client is going for a test, so endoscopy. So we're looking at the esophagus, the gastro, and duodenum. So we're looking at those three different areas. And so there are some pre-nursing procedure, during procedure, and after procedure, right? This procedure is usually a conscious sedated procedure. So prior, because they are sedated consciously, it could be done outpatient. Doesn't have to be in the hospital, but if someone comes in and they are bleeding, they probably are admitted, so we're just going to be treating them in the hospital setting. So before the procedure, we make them NPO. If it's outpatient, somebody needs to drive them home, right? Remove anything that can interfere with inserting the probe, so dentures, bridges. During the procedure, they're monitoring the vital signs. After the procedure, Sims position, make sure that the gag has returned, monitor for vagal response, monitor for perforation, right? Because they're putting their tube in, right? Anesthesia is spray at the back of the throat. That's why we are monitoring, for the gag to return, because now it's numb. So lateral position, they take pictures, they can show the pictures to the patient. They do a biopsy to make sure, if it's cancer, they can identify what it is. Next slide. So the complications, that may indicate surgery for pelvic ulcer disease would be the gastric outlet syndrome. In this case, there's mechanical impediment to the gastric emptying, or perforation, right? So perforation, there's all massive hemorrhage, which is not very responsive to fluid replacement or the EGD procedure. So these are the complications: gastric outlet syndrome, perforation, or massive hemorrhaging. And the outlet syndrome is just like it says outlet. There's a mechanical impediment to gastric emptying. Next slide. So, gastric outlet obstruction, hypertrophy, it could be due to swelling, it could be due to spasm, and it's usually most common in the pyloric area. There's atony, dilation, and there's projectile vomiting. Just like with pyloric stenosis in that child that is born, where you see that vomiting because there's no outlet. Next slide. So some of the clinical manifestation of perforation is sudden onset of severe upper abdominal pain. They may have nausea, vomiting, rigid, board-like abdomen, absence in board sounds, and that's usually very classic, board-like abdomen. And the bowel sounds will not be positive. So if you're listening to your fourth quarter, you're not going to hear anything. And you've listened for 5 minutes. Shallow, rapid respiration, and free air in the abdomen cavity. Next slide. So what are some of the surgical interventions? Well, we can close it, right? So close the perforation, vagotomy. So what they do is like they cut, branches of the vagus nerve in an attempt to decrease the rate of gastric secretion. Or Billroth 1 and 2, so where they're doing not just the vagotomy, but also they can do anastomosis with it. And a removal of the distal half of the stomach. And rectectomy. All right? Or we can do total gastrectomy. Right? Total gastrectomy. Next slide. So, post-op. Post-op care for this client. Post-operatively, well, NG tube management. And your job is to make sure that it's patent, right? And verify that it's inside the right place. So you can do the pH, right? But X-ray is the most definitive way to say that it's in your stomach, right? Observe for stability, and then we're going to record and report the output. So bright red the first 24 hours, dark red PO day 1, red green PO day 2, and looks like a bile day 3. All right? So it's expected to see bright red post-op. So we want to replace the fluid or the blood product that they've lost. And we're going to manage their pain. So coughing, deep breathing, and ambulation is really important for many reasons, right? To allow for lung expansion, to decrease atelectasis, because someone in pain will not cough or deep breathe or want to ambulate, which will create immobility complication, constipation. They don't heal as fast. DVT, pneumonia. So we want to get up and moving as fast as we can, or as they can. Next slide. So some of the post-op complications that you are concerned about after the surgery: dumping syndrome, postprandial hypoglycemia, after meal hypoglycemia, and bireflux gastritis. All right, let's talk about each one of these. Next slide. So dumping syndrome have common manifestation. And so what happens is that the food dumps into the intestine and causes hyperosmotic bolus. Because of that, it dumps, and it dumps fast, leading to rapid pulls of extracellular fluid into the bowel. and that causes the fluid to shift in the circulation blood volume, right? Causing distributive shock, which is, extensive vasodilation, leading to the activation of the sympathetic nervous system, thereby showing the signs and symptoms of dumping syndrome, which are increase in heart rate, palpitation, syncope, skin lesions, and GI symptoms. Next slide. All right, so you have the sympathetic nervous system. The parasympathetic nervous system also, they work hand in hand. One fight and the other one try to relax, right? So because of that dump into the intestine, still see that hypoosmolar bolus, right? Which leads to that rapidly pull extracellular fluid into the bowel, causes a distension in the bowel lumen. And that distension is going to activate the parasympathetic nervous system, which shows the signs and symptoms such as distension, cramping, tinnitus. All right, and so what are the signs? How do you manage it? How do you manage dumping syndrome? Well, because we don't want things to move fast, so small meals, 5 to 6 meals, right? Increase the fat, increase the protein, but let's slow down the carbs. Decrease roughage, the liquids between the meals only. Not with the meals, because it drops it faster. Develop a diet plan for the patient to prevent the syndrome itself, right? So that they understand this. Teach them about the syndrome so they understand how to manage it once they are discharged home. Next slide. All right, so we got to teach them. We have to teach them the risk factors. We have to teach them the medication regimen that they have to take. So sedative, anticholinergics, antispasmodics to slow down the transit time, stool for occult blood, and teach them when to notify the provider. Next slide. So condition of the lower GI tract is what we're talking about now. And those conditions are peritonitis, inflammatory bowel disease, which is 2 forms, Crohn's and ulcerative colitis, and colon cancer. Next slide. Peritonitis, inflammation of the large semi-permeable peritoneal double-layer membrane, right? It's covered with viscera and lines the wall of the abdomen and the pelvic cavity. Next slide. So there are some positive characteristics of peritonitis. So there are, what you see is that the positive characteristic exudates thick, fibrinous substances in response to the inflammation. Things adhere to other structures. The sympathetic nervous system causes a decrease in gastric motility, right? Because in a fight or flight, GI system's like, oh, we're not worried about food right now, right? So which inhibits the spread of the contaminant, which is good, right? Because if there's increase in motility, then things move a little faster. All right, next slide. The negative characteristics, you have a large space, unbroken, right? So now you have this space that was covered, now it's broken, and so things just, transmit contaminants, right? And then the large surface area, because it's large, it permits rapid absorption of bacteria into the bloodstream. So it's negative, not a good thing. Okay? Next slide. So peritonitis, types and causes. It could be chemical, so gastric ulcer, or ruptured ectopic pregnancy, which leads to bacteria invading the peritoneum. All right, or it could be bacteria from a trauma, ruptured appendix, which also causes pancreatitis. You can have someone who has peritonitis, peritoneal dialysis, right? All that can cause peritonitis. right? Peritonitis. So this is why when somebody comes and complain of, right lower quadrant pain, we are worried about appendix that is inflamed, because the only cure for appendix that is inflamed is surgical removal. If we do not remove it, then it's going to rupture. And when it ruptures, it causes peritonitis. All right? Next slide. So peritonitis pathophysiology, you have this inflammation. So there's shift of fluid from intravascular space to the peritoneal space, which decreases the peristalsis, free air, which increases the pressure, that increases fluid accumulation, which decreases the circulating volume, right, in that space, increases the oxygen requirement related to the increase on the pressure on the diaphragm. Remember you saw the picture where the diaphragm is located? So peritonitis is going to affect many things. It's going to affect the cardiac system. It's going to affect the respiratory system, the GI system, and if the heart's affected, then all the other system, the kidney. So it's an overwhelming infection. That's what peritonitis is. That must be treated, otherwise the patient dies. All right. Next slide. So one of the clinical manifestations, there's pain, well localized and rigid, rebound abdomen, the muscles. So that's why board-like abdomen. Increase with movement or pressure guarding behavior. So you're going to see the patient guards. There is nausea and vomiting. There's fluid and electrolyte imbalance. Bowel sounds would be not active. The respiration will be shallow. If you do a WBC, you will see that there's increased WBC. H&H will be higher. There's down a low-grade fever, usually 100 to 101. Next slide. So, for management, collaborative management, see the word collaboration means that the nurse is not an independent. We need to collaborate with the physician to treat this client. It's not an independent nursing action, right? So we have to replace the fluid and electrolyte that the patient has lost, right? Replace the lost protein, NG tube to decompress the stomach and prevent aspiration and protect them, right? So incision and drains, wound care and irrigation, culture sensitivity, and antibiotic therapy, right? Antibiotic therapy. Next slide. So what are the nursing priorities? Well, assessment, pain, quality, rate, bowel sounds, a wound care, and post-op, you want to make sure that they don't go into acute respiratory distress symptoms, make sure that they don't go into septic shock, IV fluids and antibiotic, and teaching about wound care. Next slide. Lower GI pathology. So we're starting to talk about inflammatory bowel disease. The incidents are bimodal. So you see it like, amongst two groups, 15 to 25-year-old or 55 to 65-year-old. It's equal in both male and female, and it's usually seen in individuals that are white, urban, and Jewish. It's upper middle class. There's some familial tendency and questionable if it's autoimmune or not. It's about 2 million Americans and $1.8 to $2.6 billion from lost wages, disability payments, and insurance payment. Next slide. So, not really clear. Usually when it's not really clear, they said autoimmune, genetic. Other causes will be bacteria, allergen response, increased destruction enzymes, or decreased protective mechanism. Next slide. So this is a really good comparison of the two inflammatory bowel disease, Crohn's and ulcerative colitis. You can see the difference in the picture. Cobblestone pattern, it's seen with the Crohn's versus, continuous pattern in the colon for ulcerative colitis. Next slide. So the appearance, Crohn's disease is usually small or large bowel, cobblestone pattern. You see patches. There's fistular. There are granulomas. It's edematous. Lymph nodes are enlarged. The pattern is not continuous, like we said. It's thick and it's narrow lumen versus ulcerative colitis, which only affects the colon. You see erythema, ulceration, continuous pattern. Next slide. So this slide is showing, again, really, really great comparison between the two. Distribution, the Crohn's, it's seen anywhere. Common site is determined in ileum. Ulcerative is colon, rectal, and distal colon. Inflammation is not as continuous in Crohn's, but it's continuous in ulcerative. Common manifestation, abdominal pain, diarrhea, weight loss. Ulcerative, look at that, diarrhea, rectal bleeding, so small bleeding, cramps or pain, very similar in many ways. Blood in the stool, variable, but with ulcerative, usually, right, ulcer bleed. Carcinogenic risk, it is, both have it, but is more so with ulcerative colitis. Surgery is possible, but it's not curative, right, for Crohn's, because it's so many different places, right? Ulcerative, yes, if medical management fails because of where it is. Makes sense, right? Next slide. So where's some diagnostic tests to see what's going on? You're going to do your CBC. You're going to find out that iron is low, the WBC may be high, and usually that is because the blood loss, toxic megacolon, or perforation. The electrolyte panel, the electrolytes will be low because of the diarrhea. If you do serum protein, the albumin level will be low because the disease does not allow for absorption, severe disease. And the definitive way to diagnose this is biopsy, endoscopy, biopsy. Next slide. All right, so extra-intestinal manifestation. So not just the GI system is involved, other systems are involved, right? So it can be at risk musculoskeletal to the point where they have osteoporosis, liver issues, right? Stones, pulmonary, renal, urinary tract, fistula formation. So it affects other systems. Next slide. Also affect the skin up to conjunctivitis, anemia, thrombocystosis, cystitis, embolism, right? So it's really is amyloidosis. It's really a condition that it's not selective just to the GI system, and you know that most of the system, all the systems are connected in every way. Next slide. So again, collaborative management is not an independent management only, because these guys are having lots of diarrhea. Remember you saw that? And so we want to make sure that we decrease diarrhea. And because of the inflammation, absorption of nutrients is really important. They've lost weight. So we want to increase the nutritional status, right? So that would be a goal. Next slide. So how do we manage the diarrhea, to decrease the diarrhea? Well, we need to, if it's severe enough, we're going to rest the GI tract, because when it's inflamed, it's not going to absorb nutrients anyway. So we'll make them NPO rested and put them on other ways to give them nutrition, total parenteral nutrition. Give them antidiuretic drugs, anti-inflammatory drugs, steroids, immunosuppressive, anticholinergics, anti-infectives. All right. So immunosuppressives such as the tumor necrosis factor, right? Because we want to block that. We want to block the tumor necrosis factor. Remicade is used for that. And when you give Flagyl, there's some nursing management. Make sure you look that up. Next slide. So there are some nursing diagnoses, right? So what is it? Imbalanced nutrition less than body requirement, right? Related to insufficient intake. Secondary to what? Too many things. Increased level of tissue necrosis factor, fear of postprandial abdominal pain, malabsorption, drug therapy. Look at that. Flagyl causes a metallic taste, right? So imbalanced nutrition, less than body requirement. Next slide. So drugs decrease calcium absorption in intestine, calcium excretion by the kidneys, alter protein metabolism, right? So steroids are drugs, but it causes a lot of problems. So that's why they don't want to eat, because they have all these things that is happening to them, right? Next slide. Antibiotics, also affect something. It affects the gut. It affects vitamin K synthesis, can cause diarrhea. So malabsorption, many different reasons why they are at risk for imbalanced nutrition. So the steroids, antibiotic, the disease process itself. So we need to understand that. So therefore, the collaborated goal of decreasing diarrhea and making sure that they have adequate nutrition is really important, because there are many factors that is interfering with that process. Next slide. All right. So what are some of the intervention? Well, monitoring them to make sure that they are stable hemodynamically, restore and maintain the fluid and electrolyte balance, give them nutrition, parenteral nutrition, rest their bowel, decrease immune response, so give them immunosuppressive such as Imuron. Next slide. Decrease the inflammation, diarrhea, pain, treat with steroids, treat the infection, give them anti-infectives, control diarrhea, give them antidiuretic meds, put them on bed rest, stress reduction, emotional support, and surgery if it's necessary. And it's usually for ulcerative colitis. Diarrhea, you rest the bowel, help the patient determine causative factors. Maybe they're taking in a lot of caffeine, spicy food for the skin, encourage portion intake, cleanse them, sitz bath, moisturizer, barrier cream. For acute pain, assess, alert to any complications, and use narcotic as prescribed PRN. Next slide. Teach them screening. It's really important for ulcerative colitis, right? It's really important that they need to go for colonoscopy, because they have higher risk for colon cancer within 10 years of diagnosis, right? They may have ineffective coping, right? So especially someone who's young, 15 to 25, remember? So identify ineffective coping behaviors, include the family and other staff in the plan, encourage expression of feelings, stress reduction techniques, referral to counseling and dietitian if it's needed. Next slide. So surgery for ulcerative colitis, 25 to 40% eventually would need the surgery. They would do permanent ileostomy or continent ileostomy. So pretty much that they put in a pouch that connect the end of the small intestines to the skin of the abdomen. So an ostomy outside. For Crohn's, surgery is usually not indicated except there's perforation, hemorrhage, or obstruction. Next slide. So this is the pouch. See how they edges are joined to form the pouch, and then the stoma is sutured and flush with the skin. So part of our job is to assess that stoma, make sure that it has adequate flow of blood. Next slide. So okay, so management is teaching the client about the ostomy care and stoma assessment. Make sure that it's pink, shouldn't be black. Black means no circulation. Irritating the skin, so make sure that the area is clean. There's a little pouch that we put on. Discuss medication and how to reduce the odor, because a lot of people are, body image is a problem. Discuss the food, the diet and food, and things that can actually increase the smell, like gas forming food. Maintain the drainage, and there's a reservoir. So usually the continent ileostomy reservoir is a catheter that is inserted in the stoma to drain, right? To drain. Next slide. Colorectal cancer. So there are risk factor for cancer. Age is usually the risk factor. Individuals that take high fat, low fiber diet, family history, personal history, right? So ulcerative colitis, breast, ovarian, and uterine cancer also put the patient at risk for colon cancer. This is why colon cancer at the age of 50, we screen everyone with their first colonoscopy unless there's a risk factor sooner. So then 35. Next slide. So the location, primary lesions, it could be the ascending colon, it's larger and more vascular, or descending colon is more narrow obstruction due to mass invading the bowel lumen. Next slide. So in terms of management, so we want to pretty much decrease the tumor growth, and usually by chemotherapy and radiation. We can also do surgery, resection, colostomy, or abdominal peritoneal resection. All right, next slide. So the only curative treatment of colon cancer is surgery. So it's based on the location, the extent of it, and the type of surgery. There's different ways to stage it. Duke staging, which is not used as often anymore, but it has these different stages, A, B, and even the letters are, there's other, the A, there's multiple A's, and then there's B. So generally, if you are stage A, you have 92, they found it in stage A, which means that the lesion is still in the mucosa, right, where it started off. You have a 90 to 100% 5-year survival rate, versus in stage B, which is outside of that, it's less than 15% 5-year survival rate. All right, so now they use the TNM staging, which is, it looks at T represent tumor and nose, and then M metastasis. So stage 1 to 4, 1 is in where it should be, in stage 4, it is actually spread. It's in the lymph nodes things spread out. So the bottom line is cancer is about finding it sooner, right? And that's where there's different types of prevention, primary, secondary, and tertiary. So secondary screening, with a colonoscopy, with breast exam, any type of, pap smear, we will screen to try to find it early so that the prognosis is better. All right, so pre-op bowel prep with neomycin every 4 hours for 2 days prior, because the surgery, we've got to make sure that the abdomen, because it has a lot of bacteria, so we want to clean it out. Right? Next slide. So nursing management, these are some of the nursing diagnosis that you may anticipate with a client that has colon cancer. Knowledge deficit, right? Risk for injury, post-operative complication, risk for body image disturbance, risk for ineffective management of therapeutic regimen, risk for sexual dysfunction. And things are risk until they become a problem, right? Not because I have cancer diagnosis mean that I would have body image disturbance. They have to tell you, they have to give you an indication that they are. Next slide. So for risk for injury, so post-op complication, infection, hemorrhage, wound disruption, thrombophlebitis, stoma, abnormal stoma function, right? And then, so what are we going to do for that? So dressing changes with saline irrigation several times a day to try to prevent it. Observe and record the drainage to bleeding and any unusual order and vital signs, right? Observe and record the suture, the site for edema, fever, warmth, increase in WBC. So that's what we're trying to do. We're trying to prevent the complication. That's why you set your risk mission diagnosis to make sure that that doesn't happen, right? So they're really, really very important, because actual means that it's a little too late because now you're dealing with the situation. Next slide. So sexual dysfunction is also a risk. So it's important to recognize the difference from the nerve pathways, erection, ejaculation, and orgasm. Damage to one pathway may not involve the other two. So we need to make sure we do that. So they need to talk to someone, stoma nurse or therapist, consultant. Next slide. So bowel obstruction, non-mechanical. So you can have mesenteric occlusion, and it's usually due to some type of ischemia, and emboli, AFib, diseased valves, prosthetic valves, atherosclerosis can cause mesenteric obstruction, or paralytic ileus. Paralytic is paralysis, right? Paralysis of the intestine mucosa. It's not active, right? So pneumonia, pancreatitis, appendicitis, all these things in the GI system can usually cause the stomach to have paralysis. Or pseudo obstruction, right? Pseudo obstruction, that's generally like a clinical syndrome. It's usually caused by some type of severe impairment in the ability of the intestines to push the food through. So diseases that can cause impairment, so collagen diseases, neurologic diseases, endocrine diseases. So that can cause, these are the things that can cause bowel obstruction. Next slide. So clinical manifestation, higher above the obstruction or lower, right? So this rapid onset, high obstruction, projectile vomiting, and usually the vomiting relieves the pain. Distension is minimal, and absence. There's metabolic alkalosis, right? Lower, gradual onset. They vomit is orange brown and foul smelling, right? Distension and metabolic acidosis. So what are the bowel sounds sound like? Well, the bowel sounds are high pitch over the area of obstruction, right? So above it. So in the middle, above it, proximal, it would be higher, and lower in the other ones. Large bowel vomiting may be absent with competent ileocecal valve. Incompetent valves vomit fecal material. Isn't that something? Fecal material. Yeah, so obstruction, you have people passing their bowel through their mouth. Next slide. All right, so there's some diagnostic tests. Abdominal x-ray. It's going to look at the gas and the fluid in the intestines. GI series. It would tell you the location of obstruction. CBC, it will tell you the BBC, especially if there's strangulation or perforation. H&H, down a decrease in H&H will tell you bleeding. You know, if it's increased, it's because of hemo concentration. The electrolytes, amylase, and BUN, all this can tell you. BUN will tell you dehydration, sodium level are down, amylase are up with pancreatitis. Stool, fecal blood screen for bleeding, for cut blood for bleeding. Next slide. So what are the collaborated management? We want to decompress. We want to correct the fluid volume, right? And relieve or remove the obstruction, right? Next slide. So how do we decompress? We decompress by putting an NG tube, right? Put an NG tube down to drainage. Next slide. Remove or relieve or remove the obstruction, and that's going to happen with surgery and colonoscopy, right? And so pretty much the measures for surgery, preoperative, intraoperative, and postoperative, that nursing care, is very similar to that we've discussed in the past. This ends our lecture for gastrointestinal disorders. Thank you.